Hello, my name is Leonard Ginsburg. I'm chairman of the More Eye Institute. Welcome, and the reason you're going to be watching this video is you have diabetes. And I want to talk to you a minute about that because it's so very important. We might have seen something in your eyes and tells you you have diabetic eye disease. It's one of the scariest moments probably you've ever had. I know because I was there once with a grandfather who ultimately went blind from diabetes. I will tell you, when I say that having diabetes can actually be a blessing, there's no condition in all of medicine where it's more important that the patient-physician relationship be partners, because you truly control your destiny. It is the only condition where tight blood sugar control, eating right, exercising right, which every American should do, can make you live a normal, healthy life. And that is so critical. You've got to help me. And what this means is, if you do start exercising right, if you go to a diabetes education program for a certified course, you can reduce your complications by 73%. That means you don't need me to do all what you're going to be hearing about, the laser and intravitreal injections. And why is this important? Because it's not just about eyes. Please, if you have impotence, if you are thinking you have kidney disease, if you have foot disease, are you going to a podiatrist? Are you going to a doctor who can help you with problems like impotence? Are we controlling your blood pressure? These are things that it's my honor to work with your doctors to try to maximize your health and your vision. So you kind of know a little bit about why I went into this field and why I'm motivated. I was honored to work at Joslin Diabetes Center that did preserve my grandfather's eyesight for longer than would have been. And that's why when I came back to Pennsylvania to found the More Eye Institute, we did get the best diagnostic equipment. The OCT, the #1 diagnostic test for any eye condition, just about diabetes, macular degeneration. We were the first in Pennsylvania to do that. And in fact, ICG, one of the 3 very important diagnostic tests, I had the honor of being one of the first 4 in the world to do digital ICG. Watch this video, learn about it, see what you're about to experience, and let us spend the rest of our lives working together. And the neat thing is, I once wanted to be a family physician before I actually had a grandmother who also went blind. And the reason was I get to follow patients from the beginning to the end. It's just not about a quick surgical technique. I so enjoy getting to know my patients, being there, being with each other, sharing our good times and our pain. But let it not be a lot of pain. Let it be instead where this is the first day when you start saying, let me take the advice of my family physician or my endocrinologist and let me get my blood sugar under control. And if you do that for us and you do that for your family, then if we at More can work with you to preserve your eyesight, just your most precious gift, then I've done what I want to do. And that's to be really getting to know my patients and helping them every way I can. So thank you, and please at the end of this, if you have any questions, all of our staff have been trained. We have a fabulous retina group of many doctors, and we're there to answer your questions. Thank you.
If you have diabetes, your body does not use or store sugar properly. This can cause changes in your veins, arteries, and capillaries that carry blood throughout your body, including your eyes. These changes can harm your vision. There are a number of eye problems that can be associated with diabetes, including cataracts and glaucoma. This video, however, will discuss diabetic retinopathy, a disease that damages the retina of the eye. There are 2 types of diabetic retinopathy that can lead to vision loss. One type is called non-proliferative diabetic retinopathy, or NPDR. Another type is called proliferative diabetic retinopathy, or PDR. But here, we'll be looking at NPDR. We'll meet people who have NPDR, talk about how it occurs, and what you and your ophthalmologist can do to control the progress of this disease and how to prevent vision loss. First, to understand diabetic retinopathy and how it affects your vision, let's take a look at how the eye works.
Light rays enter the eye through the cornea, pupil, and lens. These light rays pass through the vitreous, a clear gel-like substance that fills the middle of the eye. The light rays are focused on the retina, a light-sensitive tissue lining the back of the eye. The macula is a very small area at the center of the retina that gives us our fine pinpoint central vision. The area of retina surrounding the macula gives us our peripheral or side vision. The retina converts the light rays into signals that are sent through the optic nerve to the brain.
I know of 4 members in my family, all on my mother's side, that had diabetes. About 20 years ago, I was diagnosed with adult onset diabetes. And about 10 years ago, I noticed my vision was getting blurry.
Diabetes can cause your vision to change even if you don't have retinopathy. Quick rises and dips in your blood sugar levels can change the shape of your eye's lens, and this can cause your vision to blur. You can reduce episodes of blurred vision by keeping good control of your blood sugar. Also, if you have diabetes, you should see your ophthalmologist every year for dilated eye exams. This is very important because while vision loss from retinopathy can't be reversed, it can often be controlled if it's detected early. Remember, even though you may not notice any changes in your vision, your ophthalmologist may discover a problem during an exam. Let's take a closer look at NPDR and how it affects your vision.
With non-proliferative diabetic retinopathy, or NPDR, damaged blood vessels in the retina begin to leak fluids, including small amounts of blood, into the retina. Sometimes deposits of fats may leak inside the retina. These deposits are called hard exudates.
Many people with diabetes can have a mild form of NPDR that doesn't affect their vision. Problems can occur, however, if the disease progresses with conditions called macular edema and macular ischemia. Your ophthalmologist will look for signs of these conditions during your routine examinations. So, what are macular edema and macular ischemia, and how do they affect your vision?
With macular edema, fluid leaking from the retina's blood vessels can cause the macula to swell or thicken. Because the macula is responsible for our central or pinpoint vision, macular edema interferes with clear vision. Macular ischemia occurs when small blood vessels close. In this case, your macula is affected because it no longer receives enough blood to work properly.
Macular edema, where the macula swells, is the most common form of vision loss for people with diabetes, particularly if it's left untreated. There are treatments that can help to stabilize vision affected by macular edema, and we'll look more closely at these treatment options in a moment. For macular ischemia, where blood vessels in the macula close, there is no treatment.
I went to see a retina specialist, and he discovered the swelling of the macula, and that's what was causing the blurriness.
During an eye exam, your ophthalmologist will dilate your pupils and examine your retina. Because certain conditions with NPDR, such as macular edema and macular ischemia, occur inside the layers of retina tissue, it may be recommended that you have a test called fluorescein angiography, or another called optical coherence tomography, known as OCT. These diagnostic procedures allow your ophthalmologist to see blood vessels within the retina. Here's how they work.
With fluorescein angiography, a small amount of yellow dye is injected into your arm where it circulates through all the blood vessels in the body, including those in the retina. A special camera with a blue flash is then used to take a series of pictures of the retina. Any blood vessels that have been affected by NPDR will show up in these images, as well as areas of abnormal leakage or ischemia.
The images from fluorescein angiography show the ophthalmologist if any blood vessels are leaking, how much leakage there is, and if any blood vessels are closed. With OCT, a special camera is used to photograph your retina. It measures the thickness of the retina and is also very sensitive at detecting swelling and fluid. This diagnostic information helps your doctor determine why your vision is blurred and whether treatment should be started. If macular edema is found, laser surgery is often used to reduce swelling of the macula. It's usually performed in an office setting. Here's how it works.
For macular edema, the laser is focused on the retina outside the center of the macula. The laser is not applied directly to the center of the macula, since this would reduce central vision. The main goal of treatment is to prevent more vision loss by sealing off leaking blood vessels that interfere with the proper function of the macula.
Multiple laser treatments may be needed for the best results. Also, keep in mind that people who have developed blurred vision from macular edema may not recover their full normal vision.
We started with laser treatments, and that wasn't working, so we went on to medication. And I am now getting injections, and we've been doing that now for about 6 months.
Medication injection therapy is also being used to treat macular edema. 2 drugs, steroids and anti-VEGF agents, have shown promise in reducing diabetic macular edema.
Anti-VEGF drugs target a specific chemical in your eye. This chemical, called vascular endothelial growth factor, or VEGF, appears to play a role in causing abnormal leakage from retinal vessels. Several drugs have been developed that can block the trouble-causing VEGF. An anti-VEGF drug can help reduce leakage and swelling within the retina, which helps to slow or prevent vision loss, and in some cases, even improve vision.
Medication injection therapy is performed in the doctor's office. An anesthetic is used to numb the eye, and a tiny needle is inserted into the eye to deliver medication near the retina.
My vision is better. It is better. We still have a little way to go.
It should be remembered that the main goal of treatment for diabetic retinopathy is to prevent further vision loss. If you treat retinopathy early, it's not likely that total blindness will occur. Remember, treatment does not cure diabetic retinopathy, but it is often effective in preventing further vision loss. Most people with diabetes can retain useful vision. It's important to remember that you can significantly lower your risk of vision loss by maintaining strict control of your blood sugar and any medical conditions. You must also know that diabetic retinopathy can still occur even if your blood sugar is controlled. That means that you should see your ophthalmologist at least once a year, or more frequently, as recommended by your eye doctor, even if you're not having any visual symptoms. Also, if you have any changes in your vision, you should call your ophthalmologist right away. To find out more about diabetic retinopathy and how to maintain your vision, talk with your ophthalmologist.
I hope that video was informative. It taught you about the diagnostic tests we might do, the OCT, the fluorescein angiogram. It also explained to you a little bit about the treatments, whether it be intravitreal injections or lasers. You're obviously still apprehensive. If you have any questions, we're here to try to alleviate those fears. But you need to partner not just with us, but your family physicians, your internists, your endocrinologists, because if you can control your blood sugar, we can reduce complications by 73%. Let us start today treating you, and let's hope in 5-10 years you won't need the treatment because your blood sugar is under control. Here at Moore, we literally have every subspecialist in ophthalmology, and we will work as a team approach to look at every aspect of your eyes, whether it be cataract or a glaucoma or retinal diabetic disease. We're going to come up with something that's specific for you. We really are here to preserve your vision, but you have to be a partner and start taking care of yourself. It may be that I will ask an opinion from one of my colleagues. Very often, I do show charts and we share. We're blessed at the Moore Eye Institute to have a team, multidisciplinary approach where I can go next door to my cataract specialist or my diabetes specialist or my glaucoma specialist and come up with a team approach. So if you have any questions, please feel free to ask. Thank you.